Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Hair transplantation. What is the principle of hair transplantation? It was based on the basic principle of donor dominance. This concept of donor dominance was introduced by New York dermatologist Norman Orentreich. He was considered as father of modern hair transplantation. What is this concept of donor dominance? As occipital hair is resistant to androgens, if we place it in bald areas, it will grow without getting influenced by androgens. This is called donor dominance. Coming to evolution of hair transplantation. Initially, transplantation was done using punch graft of 2 to 4 mm. It gave a paddy field look or doll-like look of the recipient area and donor area, leading to cobblestone scarring. Hence, to reduce this, smaller grafts punches are developed called mini punch grafting and micro punch grafting. In mini, 6 to 8 hair can be harvested at once. In micro, 1 to 2 hair. Later, the concept of follicular unit came and then it evolved into multi-strip harvesting method. Still in multi-strip harvesting method, multiple linear scars were done, so to reduce that, only a single thin scar inducing procedure, single strip harvesting, also known as follicular unit transplantation, came. Later, without any scar, just we can do directly harvesting and implantation of hair by follicular unit excision method. This is the latest and most widely used method, follicular unit excision. And follicular unit transplantation is also based on the concept of follicular unit given by Headington in 1984. He demonstrated that hairs did not occur individually but as a naturally occurring groups or bundles called follicular units. What is follicular unit? What it contains? Each follicular unit contains 1 to 4 terminal follicles. So, hair is not individual, it occurs as a group called follicular unit. Based on this only, follicular unit transplantation and follicular unit excision is developed. Then it may contain 1 or rarely 2 vellus follicles. Then associated sebaceous lobules and insertion of erector pili muscle. Then perifollicular basilar plexus, neural fat, circumferential band of adventitial collagen that defines the unit. All these are contents of a single follicular unit without any intervening dermis. Here in the evolution of transplantation, mini and micrografts contains hair. It is small only, does not have any cobblestone scarring or doll-like look. Still, why it was not being done means it has intervening skin or dermis in between 2 hair. But here, based on follicular units, there is no intervening dermis. So, follicular unit will be very small, which is tightly packed. Here you can see 2 to 3 terminal follicles and a single follicular unit having adventitial collagen. Hence, one needs to create smaller recipient sites that allows dense packing of these small follicular units. Coming to procedure. what and all steps we have to go through while doing a hair transplantation. First, proper patient selection. Next, counseling, pre-operative workup, local anesthesia, graft harvesting. Harvesting means getting follicular units or grafts from donor sites. Then recipient site creation and graft insertion. In the bald areas, inserting the harvested grafts. At the end, post-operative care. It is very important to minimize the complications of surgery. We'll see one by one. First, proper patient selection. Equal to or more than 25 years old with good donor area hair density, that is not less than 40 follicular units per centimeter square. 1 millimeter square is equal to 1 follicular unit. Then cicatricial alopecia due to scalp injuries or burns. Then reconstruction of eyebrows, eyelashes and sideburns. Sideburns means damage to the hair present in front of the ears, this hair. For reconstruction of those hair also, we can select patients for hair transplantation. How to assess donor area? We have to assess hair density and scalp laxity. Hair density is measured using densitometer. Generally, 1 mm square will contain 1 follicular unit. 1 centimeter will contain 80 to 100 follicular units. It may vary from patient to patient. If donor hair is thick, curly and coarse, it will give an impression of better cosmetic density than straight, thin and fine donor hair. Coming to scalp laxity, a optimum laxity is important for good scalp closure. In follicular unit transplantation, we will take a strip and then we will close it. To close, if scalp laxity is good, then only it will get a good closure. To avoid unsightly wide scars and to harvest a wide strip, hence we can harvest more grafts if scalp laxity is good. These and all needed in only follicular unit transplantation. In follicular unit excision, we will directly take the graft. No need of sutures, no need to create any strip. Coming to counseling. Entire procedure needs to be explained before taking informed consent from the patient. Never overpromise. Always under-promise and over-deliver. Coming to pre-operative workup. We'll take a thorough history of past and current medical problems, medications, known allergies and habits such as smoking and alcohol. Then we'll do basic investigations, all like CBC, screening, LFTs, RFTs, every general investigation we will do. Then specifically here we will do bleeding time, clotting time, prothrombin time and ECG. If the patient is having any underlying systemic illness, we will send him for a medical fitness from physician. Then the patient should avoid 2 to 3 days prior to surgery all these things: minoxidil, smoking, aspirin and alcohol. Why? To reduce intraoperative bleeding. Photo documentation. Usually 5 sides: front, back, top and both sides of the scalp. We have to take pictures for documentation before surgery. Anxiolytics help to reduce anxiety such as lorazepam, and local anesthesia will have a pain-free surgery. Both pain and anxiety will increase the blood pressure, causing intraoperative bleeding. So to avoid that, Some hours before the surgery, we will give anxiolytics to the patient as a part of pre-operative workup. Coming to local anesthesia, we will give local anesthesia in a ring-like fashion, ring block, using adrenaline and lignocaine combination, which will work long time. We can combine with bupivacaine, it will work even more longer time. Usually lignocaine will start working in 2 to 3 minutes and last for 2 to 3 hours if given along with adrenaline. If combined with bupivacaine, it may last for 4 to 5 hours. Before giving ring block, local anesthesia need to be tested intradermally, giving a test dose for checking any hypersensitivity reaction. Hypersensitivity reaction video I have uploaded on my channel. Here we are checking for type 1 hypersensitivity reaction. What type of anesthesia? Always tumescent anesthesia is used because it helps in elevating the skin from underlying large vessels and also in achieving vasoconstriction to reduce intraoperative bleeding. What is meant by tumescent anesthesia? We will dilute the local anesthetic and we will give. What is the diluent used? Whether it may be normal saline or ringer lactate. Here we will use ringer lactate and we will add to the tumescent anesthesia triamcinolone acetate also. Why? Both these will reduce post-operative edema. After giving local anesthesia, during procedure, we have to take intraoperative care through monitoring pulse, blood pressure, and any signs of local anesthesia toxicity like perioral numbness. Visual disturbances, tremors, convulsions, and coma. All facilities, hence, for resuscitation along with ACLS, advanced cardiac life support, trained person, preferably anesthetist, should be available. After giving local anesthesia, we have to harvest the graft. That is nothing but follicular unit. How? We can do it by two methods: follicular unit transplantation, follicular unit excision. Coming to follicular unit transplantation, single strip dissection around occipital protuberance with a length of about 20 to 25 centimeters, width of 1 to 1.3 centimeters, and depth until upper subcutis is done. After trimming the hair up to 1.5 to 1 centimeter short. First we have to trim the hair 0.5 to 1 centimeter short in the donor area. Then we have to do dissection of a single strip of length 20 to 25 centimeters, width 1 to 1.3 centimeter. This skin which is dissected contains hair which is used as a graft. And then the gap or wound will be created. It is then closed using trichophytic closure technique. What is this trichophytic closure technique? Why it is used? Because to avoid a wide scar and to allow hair to grow through the thin scar. We will get two edges of a wound. One edge will slip the epidermis and will suture the both edges, believing that hair will grow through the scar. After getting a strip of 20 to 25 centimeters, we will keep it under stereo microscopic magnification and we will cut it into 2 to 2.5 mm smaller sections called silvers, and then in which excess epidermis, dermis and fat is trimmed. Finally, we will get follicular unit which is ready to get transplanted. How many follicular units we will get? 2000 to 2500, amounting to a total of 4000 to 5000 hairs. Coming to next method of harvesting, follicular unit excision. Here directly we can harvest grafts using a small punch after trimming hair up to 1 to 2 mm, very short in length. For follicular unit transplantation, 0.5 to 1 centimeter. Here 1 to 2 mm short donor area. The resultant small holes heals within a day with inconspicuous or minimal scarring. So no need of sutures, no need of worrying about scarring. So we can take from beard areas and body hair also as a donor hair. But in follicular unit transplantation, because of thin scar formation, we can only utilize occipital hair. The extracted grafts are then preserved in cold ringer lactate or saline solution, and also during procedure we have to immerse constantly these grafts into this cold ringer lactate or saline. Why? To avoid desiccation, means drying out, and which will lead to death of the follicular units. Why? Only intact and viable follicular units will result in a good uptake and hair growth at bald areas. Coming to differences between graft harvesting methods, that is follicular unit transplantation versus follicular unit excision. In follicular unit transplantation, sutures, linear scar, microscopic dissection, and scalp laxity is needed, whereas no sutures are required in follicular unit extraction. No worrying about linear scar, no need of microscopic dissection, as we are directly taking follicular units. Scalp laxity is not needed, as there is no wound formation. Beard and body hair can be used as donor hair in follicular unit excision only, whereas occipital hair only we can use as donor hair in follicular unit transplantation. We can't use beard or body hair in follicular unit transplantation. Next, we got our follicular units, nothing but grafts. Next, we have to insert it in desirable areas, that is bald areas. How? First, recipient site creation and then graft insertion. Recipient site creation instruments we use 18 to 19 gauge or no-car needles, slits, rectangular punches and blades. After creating recipient sites, graft insertion can be done by two methods, stick and place method, which involves making a recipient site and then inserting the graft immediately into that recipient site, whereas in preformed slits involves creating all the required recipient sites together and then placing grafts one by one, which means if we have 4,000 to 5,000 grafts, we will create 4,000 to 5,000 recipient site slits at a time together. Then we will take grafts one by one and insert into the preformed slits. Whereas in stick and place method, one recipient site, one follicular unit, then another recipient site, another follicular unit. Here, all the recipient sites are preformedly prepared. Finally, advanced technique using implanters like CHOI or KNU pens. In the pens, we will load follicular unit and it will create recipient site and then it will insert those follicular units simultaneously at a time. No need of prior recipient site preparation from our side. This pens will take care. This is called implanter pens. Normally we will create recipient site and then we will plant the graft or insert the graft, whereas in implanters it will do both the work by itself. How we have to create recipient sites? In what direction? In the direction of, in a parallel direction of existing hair at a depth of 4 to 5 mm to avoid damage to deeper vessels. We will see the existing hair's direction. Parallel to that, we will create recipient sites to insert our grafts. If the patient combs from left to right, we will insert more grafts on left side. To have a good cosmetic outcome, it will give an impression of huge hair density. As he combs from left to right, we have to implant more hair on left side. Single hair follicular units are used to reconstruct frontal hairline, and larger grafts having 2 to 3 hair are placed behind the frontal hairline. PRP can be done along with insertion of grafts at recipient site. Why? It will improve the survival of graft as a holding solution, as it contains growth factors, vascular endothelial growth factors. It will improve the survival of the graft. After transplantation, majority of the transplanted hair will fall off within 2 to 4 weeks. It is due to telogen effluvium. As hair transplantation is also a surgery, surgery-induced stress leads to telogen effluvium. Then growth will begin only from 4th month at the rate of 1 centimeter per month. Optimum growth is seen in men in 9 to 12 months, in female 18 months. Female optimum hair growth is lengthier than male, so it takes 18 months. Coming to the end, post-operative care. A good post-operative care will avoid or minimize the complications of surgery, which are rare and minor. Though complications are very rare and minor, good post-operative care is needed. We have to avoid smoking, alcohol, exertional work, heavy exercises involving head and neck for about a period of 2 weeks from the surgery. Oral antibiotics and analgesics have to be started from the day of surgery. Finasteride can be started the very next day. Minoxidil only after 1 week of surgery. If non-absorbable sutures are done in case of follicular unit transplantation, it should be removed after 2 weeks. Wound care. First 3 to 4 days, the wound created at donor area and recipient area should be cleaned with cold compresses, that is sterile, normal, saline. To maintain a moist environment at the recipient area is important for the survival of the grafts and to prevent crust formation. If at all any bleeding occurs, we have to control it by firm pressure application or cold compresses. How cold compresses will control bleeding? It will stimulate clot formation and it will lead to vasoconstriction. Periorbital edema becomes evident after 3 to 4 days. For that, we have to treat with ice packs around the eyes and advise the patient to sleep laterally. And also, we can prescribe low doses of prednisolone for 3 to 4 days. Post-operative pustules can be seen in 2 to 3 months. It is due to piggybacking of grafts. That means more than 2 follicular units are inserted in the same slit. So, pustules may form later and it will self-resolve on its own. If it's not resolving, we can drain. Remember the channel name, The Average Dermadoc. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.